This lecture is about acute meningitis. Meningitis means inflammation of the meninges, and the cutoff for deciding whether it's acute or chronic is 7 days of symptoms. Any symptoms longer than that are considered chronic meningitis, which has a different range of etiologies and will not be considered further in this lecture. It's important to note that acute meningitis is more common in children than adults, although this lecture will focus on adults. There is a long list of likely pathogens, notably viruses such as enteroviruses, mumps virus, and herpes viruses can all cause acute meningitis. Various bacteria, particularly Streptococcus pneumoniae, Neisseria meningitidis, Haemophilus influenzae, and Listeria monocytogenes, cause bacterial meningitis, and there are some rarer causes such as tuberculosis, fungal infections, and helminths, and also some non-infectious causes such as drugs and malignancy. You first need to decide if a patient is a suspect for acute meningitis based on their clinical features. There are 4 cardinal features. If any 2 are present, then the patient should be suspected of acute meningitis. Those 4 are headache, fever, neck stiffness, and altered mental status. There are various supporting clinical features such as photophobia, vomiting, and a blanching or purpuric skin rash, and these should all be taken into account when considering whether to investigate a patient further. Acute meningitis is a medical emergency, and there are 3 critical actions that you need to consider, and time is critical. The patient is going to need antibiotics, a blood culture, and a lumbar puncture. The lumbar puncture should always be done first if it's safe to do so, but antibiotics should never be delayed so that a lumbar puncture can be performed. So you first need to consider if there are any contraindications to lumbar puncture. These are divided into neurological and non-neurological contraindications. This is a suggested flow diagram of how to investigate patients suspected of having acute meningitis. The first thing you need to consider is whether there is a contraindication to a lumbar puncture before a CT brain. The level of evidence guiding this advice is limited, and it's largely based on expert opinion and experience, but in general, a lumbar puncture is contraindicated prior to a CT brain if the Glasgow Coma scale is less than 10, or there is papilledema or the presence of a VP shunt, if there's an unexplained seizure, or unexplained new focal neurological deficit such as hemiparesis or dysphasia. But note, having isolated cranial nerve pools in itself is not a contraindication to lumbar puncture. So if one of these contraindications exists, then lumbar puncture should be deferred, and you should take a blood culture, and immediately after that's done, give the first dose of antibiotics. In a South African setting, there may or may not be a CT brain immediately available. If there is, then the CT brain should be done, and look to see if there's a contraindication to LP on the scan. If not, you can do the lumbar puncture. If there is, then you'll have to delay the lumbar puncture and continue with antibiotics. If CT scan is not available, then you have no choice but to continue with the antibiotics. On the other hand, if there's no contraindication to lumbar puncture without CT scan, you have to look for non-neurological complications. Again, the evidence base for this is limited, but in general, someone with severe cardiorespiratory compromise who is unable to lie flat, or someone who has clinical evidence of abnormal bleeding, such as an advancing purpuric rash or sepsis over the LP site, should not be having lumbar puncture. If those are present, you should take a blood culture and then give antibiotics. If the contraindication resolves, you can then perform a lumbar puncture. If none of these are present and it's safe to do a lumbar puncture, this should be done first, then a blood culture should be taken, and lastly antibiotics should be given. The initial antibiotics in an adult should be ceftriaxone 2 grams given intravenously. It's important to note that penicillin allergy is not a contraindication in itself unless it was a life-threatening reaction, although a known allergy to ceftriaxone itself would be a contraindication. Ceftriaxone does not treat Listeria monocytogenes, so in patients who are at risk of this infection, you need to add ampicillin 2 grams 4 hourly. The risk factors are not well described, but in general, any patient greater than 50 years or immunocompromised due to long-term steroids or chronic alcoholism, for example, should be treated with ampicillin in the first instance. Remember that acute meningitis is extremely painful and we should give adequate pain relief. In the South African setting, there is no indication for steroids at this point. This algorithm suggests how you should deal with the patient after the first dose of antibiotics. If the lumbar puncture was contraindicated, then you have no choice but to continue antibiotics, and if the contraindication resolves, you can then perform a lumbar puncture. If the lumbar puncture was performed, the first piece of information you'll get back is a gram stain from that fluid. If the gram stain is positive, then the diagnosis is confirmed, and you should continue antibiotics and direct your therapy based on the culture and sensitivity results once they're available. If the gram stain is negative, the next piece of information you'll get is a cell count, protein, and glucose from the CSF. You may also have access to a procalcitonin or a CRP and a cryptococcal latest antigen test in a patient with HIV. If the CSF is entirely normal and the inflammatory markers are normal, or the CLAT is positive confirming cryptococcal meningitis, then it's safe to stop antibiotics, seek an alternative diagnosis, and if the CLAT is positive, refer to those guidelines for treatment. If these parameters are abnormal, you must continue the antibiotics while waiting for the results of cultures. If the CSF or the blood is positive with a typical meningeal pathogen, such as Streptococcus pneumoniae or Neisseria meningitidis, then the diagnosis of bacterial meningitis is confirmed, and you should continue antibiotics and give directed therapy based on these results. Things become more difficult when these cultures are not positive. So that's to say, patients who've had an abnormal lumbar puncture, but a negative culture from both blood and CSF. The next decision you have to make is after around 48 to 72 hours. You should assess the patient clinically, and if they've got normalization of their signs and symptoms, and this is not strictly defined, but essentially the patient's feeling better and there's an improvement in their vital signs, then you should consider that they do have bacterial meningitis and continue antibiotics for their recommended duration. If there's no improvement at this time, it's sensible to repeat the lumbar puncture. If the lumbar puncture is significantly improved, then it's likely that the antibiotics are working and the patient has bacterial meningitis and you should continue treatment. If the lumbar puncture is not improved, then clearly your antibiotics are not working and you should stop them. Alternative diagnosis should be sought, and in particular, you should send a large volume of CSF for mycobacterial culture and consider empiric TB therapy if you think this is likely. If bacterial meningitis is confirmed in this way, we need to continue antibiotics. If we have no positive cultural results, either from the CSF or the blood, then we should treat with ceftriaxone 2 grams 12 hourly for 10 days. This is the standard treatment for pneumococcal meningitis, and that's what we should assume. If bacteria are cultured, then you will by definition be in contact with a microbiology department who can give you advice. Streptococcus pneumoniae should be treated with either ceftriaxone or penicillin depending on the sensitivities for 10 days. Neisseria meningitidis is almost always sensitive to penicillin, and treatment is for 5 to 7 days. So in summary, acute meningitis is a medical emergency. Antibiotics should be given immediately and only delayed for immediate lumbar puncture and blood cultures. The first dose of antibiotics should be ceftriaxone 2 grams intravenously. A positive CSF gram stain or culture from blood or CSF confirms the diagnosis. If CSF is entirely normal and CRP or procalcitonin are low, bacterial causes are effectively excluded. If the diagnosis is in doubt, after 48 to 72 hours, you should repeat the lumbar puncture. If bacterial meningitis is confirmed, but all cultures are negative, you should give ceftriaxone 2 grams 12 hourly for 10 days.